So today we will talk about hyperpituitarism, in which the pituitary glands it starts functioning more. The most important cause of hyperpituitarism and most frequently found are benign tumors. These tumors they can be prolactinomas, they can be growth hormone secreting tumor, and then there can be ACTH secreting tumors. Now, first of all, we will discuss about prolactinomas. Prolactin is actually a hormone which is produced by anterior pituitary, and normally it is not produced. It is under continuous inhibition by the release of dopamine by hypothalamus. This dopamine it keeps prolactin inhibited, and this prolactin is released only in certain conditions, for example, pregnancy, sexual intercourse, and during lactation. And pathologically, it is produced in excessive amount if there is a tumor which is called prolactinoma, which is a benign tumor of pituitary gland. So prolactin level, it can be raised in prolactinoma, and it can be drug induced, for example, different antipsychotic drugs. Then it can be idiopathic, kidney failure, and liver cirrhosis and thyroid problems. When prolactin level is increased, what symptoms it can produce? We will discuss it now. It can produce menstrual irregularities. It can produce decrease in libido. It can produce pressure symptoms because optic chiasma is closely related to the pituitary gland. When chiasma is compressed, it can produce bitemporal hemianopia, and then it can produce fertility problems like infertility. It can produce galacturia, that is the secretion of milk from the nipple. As you can see, again, these are the symptoms which are shown in the illustrated form, that it produces menstrual changes, erectile dysfunction, milky nipple discharge, decreased libido, and infertility. These are the levels of the prolactin. You can see that in microprolactinoma, the levels are between 100 to 250. In macro, it is 200 to 1000. While in non-functioning pituitary adenoma, which do not produce any hormone, it can be less than 100, 25 to 100. Mainstay of treatment of prolactinoma, they are medications which are dopamine agonist, and they can decrease even the size of the tumor. But if they are not effective, then we have to go for surgery. Now we will come to increase production of the growth hormone by growth hormone producing tumor. So this produces acromegaly. An acromegalic patient has prominent supraorbital ridges, visual field defects. Then there is progantherism, that is protrusion of the lower jaw, white spaces between incisor teeth. Then there can be goiter. Then hypertension, and spade-like hands and finger size is also enlarged. And these patients they also have diabetes mellitus. How do we investigate acromegaly? We can investigate it by MRI, and we can see insulin-like growth factor in the blood, they are raised. Then we can go for glucose tolerance test, and when glucose is administered in acromegaly, growth hormones is failed to be suppressed, and it remains high. The treatment of the acromegaly is, number one treatment is transsphenoidal surgery. Then number two treatment is somatostatin analogs, and then after somatostatin analog comes growth hormone antagonist like pegozamin, and finally dopamine agonist. And somatostatin analogs they are most effective drugs. And the third tumor we have already discussed, ACTH producing tumor, Cushing syndrome. I have discussed it in the previous lecture. Thank you very much.